I'm going to share a few things with you in terms of my perceptions of practice changing, updates, as well as a discussion of our model of care. Dr. Gort specifically asked me to share a bit about that has changed somewhat, but I, again, much appreciate the opportunity to present. I do not have any financial relationships to disclose, and I will not disclose any off-label use or investigational use in my presentation. A couple of things I will cover, and we'll be highlighting the roles of hospitalists in the perioperative evaluation and management of patients, understanding the impact of the timing of surgery and outcomes in patients with recent SARS-CoV-2 infection. We'll talk about applying newer validated risk scoring systems in patients with cirrhosis undergoing elective non-cardiac surgery. And we'll discuss managing anticoagulant therapy appropriately through the surgical episode, including decision-making regarding bridging therapy. Now, these are fundamentally predicated on articles that have come out in the last 2 to 3 years. I will refer to some older articles, but certainly some of this will be discussion of concepts as well. So let's talk about the role of hospitalists in perioperative care. In reference to what we do at the Cleveland Clinic, we historically had a clinic called the Internal Medicine Preoperative Assessment, Consultation, and Treatment Clinic. This was a hospitalist-run preoperative clinic that worked closely with our anesthesiologist. Unfortunately, in 2020, this had to close for the most part due to some organizational issues. It was replaced by an advanced practice provider-based anesthesia-run clinic, with the exception of one clinic that's still active in the ophthalmology area with 2 advanced practice providers. I will talk about some future directions, especially in terms of co-management. We are active in co-management with both neurosurgery and orthopedics, and we are engaging our surgeons directly with selected high-risk preoperative evaluations. So one thing that I will highlight, again, this is all material I'm happy to share, is that concept of the preoperative process model that you see on the right, where essentially with some form of questionnaire, after a surgeon decides to operate on a patient, how do you determine that that patient has medical comorbidities that require your input? So in the past, we had a tool called HealthQuest, which you see here is a computer-assisted health screening tool. I will share with you questions that are aligned with HealthQuest for you to use on your own. And if it's determined that the patient is quote unquote unhealthy, if required by further testing, then we would engage medical consultation as well as medical subspecialty consultation, such as cardiology or pulmonary. If they do not require a further detailed medical evaluation and is a fairly healthy patient, then we have an express pathway which gets the patient to the anesthesiologist and then to surgery. Several of anesthesia and internal medicine colleagues at Cleveland Clinic collaborated on several of these algorithms we have for patient management of patients with these different comorbidities. Some of these conditions have evolved. And the other thing I would highlight is that medicine and anesthesia collaboration is a nationwide and international opportunity with the Society for Pre-Op Assessment and Quality Improvement, which I want to highlight started out of the Perioperative Medicine Summit that started at our organization, the Cleveland Clinic, in 2005. Highly recommend that you take a look at spaci.org for some great resources and opportunities for collaboration. So this is a paper that we wrote back in 2017 that really serves as that framework for high value, high quality collaborative care. So several of these folks are involved in the perioperative and consultative world of Society of Hospital Medicine. But I really think that this is useful to sort of serve those constructs as to what do the different roles entail for surgeons, anesthesiologists, and hospitalists. As you can see, the roles of hospitalists at the bottom certainly are to identify those medical issues, optimize medical conditions, and provide anticipatory guidance, meaning if this were to happen, do this. So it gives that idea for other caregivers of here's what we need to do for these medical conditions. The day of surgery, identify any acute decompensations, and certainly in the post-op, inpatient, and post-discharge spaces where we probably add even more value in terms of ensuring that those medical comorbidities are optimized and that appropriate medications are resumed and that there is an appropriate transition of care to the post-discharge space. Certainly, this has been a point of conversation with anesthesiologists because they do not typically engage in the post-discharge space. And I welcome insights from you in Brazil if that is different. And also, it is a core competency of the Society of Hospital Medicine. And I hope that you all are familiar with this document that we initially created in the 2007 or so and was revised in 2017, which is a series of documents around what are the core competencies of hospitalists. And this is the statement regarding medical consultation and co-management. Hospitalists provide expert medical opinion for patients going for surgery. They also active in co-management of such patients, and co-management reduces hospital costs and improves healthcare perception of care quality. And this is all, of course, predicated on effective and frequent communication between hospitalists and resulting clinical services. So, what exactly is co-management? Co-management is the concept that a provider, such as a hospitalist, engages and takes ownership of a specific niche of the patient's care. For example, if a patient has a knee replacement and they have diabetes and high blood pressure and coronary artery disease, that the hospital-based internist takes ownership of that care of those medical comorbidities while the surgeon manages the wound and the post-operative care that's in general. One thing that's important in terms of co-management, these are two papers by my colleague, Dr. Nidhi Rahatki, who's at Stanford, truly highlights the value that is brought. So this is at Stanford University, a single center study that she looked at pre-co-management years 2009 through 2012, and then the co-management service was established there with orthopedics and neurosurgery in 2012. And I will highlight that this was a propensity score analysis that denoted a significant differential decrease in the proportion of patients with one or more medical complications, with patients with length of stay greater than or equal to 5 days, a decrease in 30-day readmission rate for a medical cause, and the decrease in the engagement of two or more medical consultants, essentially, which also is important because the more medical consultants are involved in the care, the more tests are ordered and the longer is the length of stay. There was not a change in patient satisfaction. Provider satisfaction was high, upwards of 88%. And you can see in US dollars, the estimated average savings of between $2,600 and $4,300 per patient in the post-surgical co-management group. Now, Dr. Rahatki did a 5-year follow-up article in 2020 that noted a continued decrease in medical complications by about 3.8% per year, as well as a length of stay decrease by 0.3 days per year. And certainly in U.S. hospitals, and I'm interested to hear if Brazilian hospitals are similar in terms of the bed capacities, especially during COVID. And now we are undergoing the challenges of both influenza and RSV. So hospital bed availability is a very important resource for us to cultivate. In addition, Dr. Rahatki noted that there were decreased rapid response calls by about 12% per year. And again, estimated average direct cost savings sustained of $3,424 per discharge. So this is a great justification to your organizations to say this is the reason why hospital-based internists or family medicine trained medical providers should be involved in the care of these surgical patients in a systematic way that makes sense. The other thing I would highlight is that this is a debate that we had published. Dr. Katrina Harrop, who's a hospitalist at Jefferson, published this with two anesthesiologists. Dr. Hepner is at the Brigham and Dr. Galore is at Duke University, about a debate between should hospitalists versus anesthesiologists run preoperative clinics and perioperative care. The first bullet point is essentially a summary here of all the different core competencies that in hospital medicine of the article I highlighted earlier. These are all the things that hospitalists are invested and engaged in. And I'm sure all of you invest and engage in these different domains of work to ensure that the hospital-based care is improved. One concept that's important is that most perioperative outcomes research, such as with the condition called myocardial injury and non-cardiac surgery, non-cardiac death, et cetera, look at 30-day mortality and longer-term outcomes. As certainly in our country, those patients are discharged to home or to a facility long before that 30-day mark after elective surgery. Thus, it is critical that we transition care effectively back to the primary care provider and the post-discharge space. Then that is a fundamental principle of practice for hospitals. And in fact, if you looked at the term transitions of care, the Journal of Hospital Medicine since 2006 has 2,609 results. That's about 4 times as many results as is noted in the flagship journal Anesthesiology. So I will have her highlight that this is not a which one is better, because certainly as uh, Dr. Kurt Pfeiffer, a great colleague in the internal medicine perioperative space, published this editorial to our debate that said, yes, together we are stronger, and we truly collaboration is better than confrontation in this space. So try and ensure that you network and engage with your anesthesiologists and surgeons to talk about this value, both from the co-management standpoint and from the preoperative space. This is a slide I usually talk about when our surgeons ask us to clear patients. And I think this is an important concept to cover. I'm not sure if you typically have the question of, quote, clearance. We often get that as well. And so we like the term optimized. And so what the flight analogy refers to in that plane, and by the way, that is Princess Juliana Airport in the Virgin Islands, where folks sit on the beach and planes land very close above them. The concept of the flight analogy was put forth by Dr. Frank Machota, who was one of my mentors, as well as Dr. Amir Jaffer, who was one of the leaders in the Impact Center and in the perioperative space. They published this concept that the patient is the plane and the surgical journey is the flight. The surgeon is the pilot of the plane. The anesthesiologist is the co-pilot of the plane. So we, as practicing internists and hospitalists, are the mechanics at the top right of the screen to ensure that the plane is in its optimal flying condition. Now, realize that different planes have different sizes and tolerance for journeys. So a plane that's a twin engine plane may be able to take a smaller journey in the surgical milieu. That could be a carpal tunnel release, as opposed to a larger plane that would be more robust and be able to tolerate a much longer journey, such as a Whipple procedure. So realize that that's a good analogy to leverage to think about risk assessment of risk of patient and risk of procedure. And then I use the term the clinic test in terms of testing to say, if you were to see this patient in an outpatient clinic and they weren't going for surgery, would you do this test anyway? And in principle, that is a great way to think about perioperative care and appropriate lab testing, things like that. So this is a template that you can use for medical consultation indications. This is something that you may leverage, and I'll show you another slide that will highlight this, but these are examples of what comorbidities or conditions you can focus on in order to identify patients for medical consultation for surgery. And then similarly, we actually developed this preoperative questionnaire with our anesthesiologist that you can essentially provide to your patients to identify if they are appropriate for medical consultation. So our principle was that any one of these that were answered yes would be a trigger for appropriate medical consultation. If a patient has had none of these answered yes, then they can be expressed through and probably do not require an internal medicine evaluation. This is also a grid that we leverage, and the term PACE is preoperative anesthesia consultation and evaluation. That is our anesthesia clinic. The concept here is that you're assessing risk of patient on the y-axis here with health quests, which is the severity of medical illness, and then surgical risk of low, intermediate, or high. And so if patients have fairly healthy status, they truly don't require medical input, whereas if they have higher comorbidities, then certainly medical input is more warranted. And then this slide also is from a Canadian paper called Drop the Pre-op, which also gives you more granular detail as to how you might go about this and recognizing patient physiologic status, and there's details there, versus surgical categories that give you the concept of which of those patients in terms of risk of surgery and risk of patient, what more granular input would you need? And in most of these, if they're undergoing a fairly robust procedure and they have any sort of systemic disturbance, our investment is certainly appropriate. Certainly, the other thing I will share with you, and I'm happy to share these offline, are templates. It's important to think and develop these templates because these really, you can design these to make them evidence-based in your medical record. We use a medical record called EPIC, which is very commonly used in the US. I really like templates because it makes it easy for folks to do the right thing. You don't have to remember all the granular details of the evidence based pathways. If you build it into your template, you make it easy to do the right thing. So recognize that and certainly develop that in your organizations. Let's move on to the timing of surgery and SARS-CoV-2. So here's an example case that this is a 56-year-old male who's had a stent to the left anterior descending artery 2 years prior and is on these different agents for both hypertension, diabetes, and coronary disease. Diabetes is on Lantus in 50 units in divided doses. He is scheduled for elective knee arthroplasty in 1 week. In 10 days prior to the visit in your preoperative clinic, he had COVID-19 clinical disease confirmed by testing, and he was not vaccinated. He still reports residual fatigue, cough, and dyspnea, and his exam shows scant wheezes and rhonchi in the lower lobes bilaterally and is otherwise benign. His O2 sat is 92% on room air with a heart rate of 96, and please note he is on metoprolol. So what is the ideal time frame for this patient to have surgery? Would you take the patient to surgery in 1 week, 4 weeks, 7 weeks, or 14 weeks? And so while you contemplate that, we'll go through some literature from the COVID Surge Collaborative. The COVID Surge Collaborative really started in the summer of 2020 and noted about a 38% mortality in patients undergoing surgery, primarily from obviously pulmonary, postoperative pulmonary complications, as well as venous thromboembolism. The American Society of Anesthesia and the Anesthesia Patient Safety Foundation in December of 2020 posted their recommendations and joint statement regarding the timing for surgery, and they suggested as little as 4 weeks, but as long as 12 weeks, depending on the severity. However, the timing of this is a subsequent paper in 2021 regarding this from the COVID Surge and Global Surge Collaborative. This is a multi-center prospective cohort study of over 140,000 patients in 116 countries undergoing elective or emergency surgery in October of 2020. About 2.2% of those 140,000 patients had SARS-CoV-2 infection. And you can see that the risk of postoperative mortality was significantly higher, upwards of 6 weeks. And once the patients got out to 7 weeks, that mortality decreased. What we know is that in other domains in this paper, it was even greater risk if the patient was still symptomatic. And these other domains include age, ASA class of 3 or greater, revised cardiac risk index score greater than 1, if they had surgery for cancer, major surgery, or emergency surgery, all were predictors of worsened outcomes. So the guidelines then were updated by the joint statement by the ASA and APSF in February of this year, specifically saying a 7 weeks delay is appropriate in unvaccinated patients. There is insufficient evidence currently for recommendations in vaccinated patients. If surgery is required during a period of increased risk, highlight those risks in the conversation with the patient as an informed consent with shared decision making. Obviously, consider the severity of infection, consider their comorbidities, their frailty, and their surgical complexity. I do anticipate that this 7-week time frame probably will be reduced as we get more experience and immune profile with the virus. But again, at this point, that's where our guidelines are. In the UK, this is what their recommendations are as a multidisciplinary consensus statement. They specifically say there is no evidence on perioperative outcomes after SARS-CoV-2 vaccination and the Omicron variant. It is assumed that asymptomatic or mildly symptomatic infection does not likely add risk. That assumption is currently unfounded. So realize that we do not know the degree of what that will do. They do suggest individualized risk assessment for patients with elective surgery planned within 7 weeks of SARS-CoV-2 infection. So really the line is 7 weeks, even if they're mildly symptomatic or asymptomatic, and recognize that if they need to have surgery sooner, there's a risk that you're taking. It's not to say that they can't have surgery, but that's the risk-benefit conversation that you have to have. Let's move on to liver disease and surgery. I do realize that you had a presentation yesterday regarding this, but I will cover this from some guidelines that have come out. Here is a gentleman who has a history of alcoholic liver cirrhosis, has been abstinent from alcohol for 8 years, also has gout and diabetes. He is scheduled to undergo a colectomy for colon cancer in 3 weeks. He has complications including ascites and grade 2 esophageal varices. He's being managed with furosemide, spironolactone, and nadolol. His blood pressure is 94 over 58 millimeters of mercury. His heart rate is 66 beats per minute. He is alert and oriented. He has moderate ascites on physical exam, as well as lower extremity edema. He does not have evidence of asterixis. His labs reveal a hemoglobin of 11 grams per deciliter, platelets of 92,000, the sodium of 128. Albumin is low at 3. His total bilirubin is elevated at 2.2. Serum creatinine is 0.8 milligrams per deciliter, and his INR is 1.5. So, would you proceed to surgery with this patient? Would you delay his surgery, or would you cancel his surgery? Now, as you contemplate that, we'll move on to a couple of reviews that came out in the last 2 years that was really highlighted the idea of what is the impact of cirrhosis on surgery. This was a review of a database called the Nationwide Inpatient Sample between 2005 and 2014. It was noted that about 20 to 25,000 patients with cirrhosis undergo surgery in the U.S. per year. We know that cholecystectomy rates actually decreased. Orthopedic surgeries approximately doubled, and hernia surgeries increased about 31%. So what we did note is that, as you can see in this graph, these are in-hospital mortality rate and overall hospitalization mortality rate from these different types of surgeries. And you can see the highest risk are major abdominal surgery and with major cardiovascular surgery. And keep in mind that this is also, I would highlight that this is highlighting that this graph highlights emergent versus non-emergent. This graph highlights compensated versus decompensated. So graph A is urgent or emergent versus elective. So urgency of surgery predicts much risk, whereas certainly for cardiac and abdominal surgeries. And certainly when you look at the risk of decompensation, is there compensated versus decompensated? Decompensated cirrhosis also confers a much larger risk of morbidity and mortality. This is another paper that really highlights this. This is a useful graphic that dictates the impact of liver disease on surgical outcomes. And you can see the things I've circled in red are things I would like to emphasize too, is that bleeding risk is still present, but realize that the level of prothrombin time is actually fairly unreliable as a predictor of coagulation status. So realize that patients with an elevated PT or INR in the setting of liver disease may still be prothrombotic. And so they still may be at risk for venous thromboembolism and clotting. And as highlighted on the right here, both thrombosis and bleeding can be a consequence of liver disease. Also recognize that there is a chronic vasodilatation. So realize that when patients have induction with general anesthesia, there is a vasodilatory phenomenon and can lead to significant hypotension and organ hypoperfusion. Probably one of the biggest things that's important to note is pulmonary risk. Is well known that postoperative pulmonary complications are approximately twice as common as cardiovascular complications and probably have a greater association with morbidity and mortality. And that these are things that we know can be consequences of liver disease in the pulmonary state: hepatopulmonary syndrome, atelectasis, pleural effusions, and portal pulmonary hypertension. Another thing that's very important to note, and I highlight this, is the nutritional risks of liver disease. These patients oftentimes are malnourished with sarcopenia and micronutrient deficiencies that can certainly lead to risks of infections, risks of impaired wound healing, and other surgical complications, and not just liver-related complications. So, liver disease is certainly challenging in the perioperative state. So, how do we assess risk? The classic tools include the Child-Turcotte-Pugh score, or the child score. It's recommended that Class C disease was prohibitive in this domain. The MELD score, which was a tool that, of course, the model for end-stage liver disease, which was also used as a post-TIPS prognosis tool, and then subsequently pivoted to use for liver transplant. A score greater than 15 generally was considered prohibitive. Dr. Tay in gastroenterology in 2007 from the Mayo Clinic published their morbidity and mortality calculator online. And so what I did was I plugged our patients' data into this tool to see what the probability of morbidity and mortality. And these two calculations highlight the differences between compensated at the bottom and uncompensated disease at the top. So you're looking at uncompensated or decompensated cirrhosis gives you a risk upwards of 20% mortality at 30 days, whereas if it's compensated, that risk is down to 5%. So realize that compensating that disease state from a cirrhosis standpoint is quite important. Um, these are this is two articles that highlight a recent tool called the Vocal Pen Score. Dr. Mahmoud and his colleagues from the University of Pennsylvania published this, and this is a tool that was actually leveraged and looked at as an online tool, and I'll show you an example of that was found to actually have a better performance than the Mayo MELD or Child's Turcotte Hue score. And this is an internal derivation and validation study. For those of you who are not familiar with the derivation and validation terms, scores are derived from a population of patients. And the question is, how do you know that your score is only dependent on that patient population? So you take the tool and then you apply it to another set of patients, and that's your validation process. And you can see here that the Vocal Pen score had a higher area under the curve for 30-day mortality in both of these cohorts compared to these other tools. And they include MELD and MELD NA, which includes the sodium level. When you look at 90-day mortality, a similar curve emerges for this tool as well. Now, this is where they actually subsequently took this and externally validated at another hospital system in the US, which is Beth Israel Deaconess in Boston, as well as other hospitals in the University of Pennsylvania Health System. And again, this is the curve for not 30-day and 90-day mortality. Now, this actually performed just about as well as Mayo in the 30-day and a little bit better than Mayo in 90-day. But again, you can see that this is where you have to apply this to different populations. So it's another useful tool. Both Mayo and Vocal Pen are available online. Vocalpenscore.com is where you can find this. You can enter that data in there and get your predicted outcomes. And certainly the importance with this is that both this and the Mayo tool, you can bring back to the patient who you may be evaluating for surgical intervention who has cirrhosis and say, okay, what is let's discuss what the risks will be. What other surgical or non-surgical options might you have, and how might we approach the surgery with the recognition of that risk? Certainly, the other things I would comment on that's important is to ensure that you optimize your patients in an optimal way. Nutrition is quite important as part of this process. Ensuring that if you are able to get the patient to an experienced center who deals with liver disease, both surgically and medically, that's quite important. Make sure you correct coagulopathy, thrombocytopenia, cryoglobulin if fibrinogen is less than 100 milligrams per deciliter. Recognize some caution with regional anesthesia with that coagulopathy. Recognize, as we talked about before, euvolemia is important for mitigating splanchnic vasodilatation related to induction of anesthesia. Minimizing opioids and sedatives. Tapping or doing a paracentesis for ascites, especially for abdominal surgeries. I was challenged by when I presented this similar data before as to, well, if you're opening up the belly anyway, why do you need to tap the patient? And I think that just opening up the belly and taking out the ascites intraoperatively doesn't necessarily mitigate the hemodynamic shifts that you have to deal with in the surgery. So tapping the ascites before the surgery, so there's some equilibration of that acidic gradient in conjunction with diuresis and in conjunction with optimizing the coags will be a part of that. And certainly one of the sort of end options certainly is evaluation for liver transplant. There's also literature suggests that procedures such as a sleeve gastrectomy for non-alcoholic steatohepatitis is also helpful to ensure that the liver disease can be optimized as best we can to mitigate that. I have references for that area. And now I move on to the perioperative management of anticoagulant therapy. So I think this is one that's very important. And I oftentimes, this is an older slide. I love to quote Shakespeare, whether it is nobler to the mind who suffer the pain and swelling of outrageous thrombus, or to take arms against a sea of hemorrhage. So what is bridging? Bridging is the use of an alternate shorter acting anticoagulant in the immediate perioperative period to minimize the risk of arterial and venous thrombosis in patients with significant risk factors. This can include atrial fibrillation, of course, mechanical heart valves, venous or arterial thromboses, and then hypercoagulable state. Please, it's noted that upwards of 10 to 12 million patients worldwide annually are assessed for bridging. And I want to cover a couple brief trials that I think you all should be aware of that really highlighted this. It was often that we defaulted to bridging as a safe and appropriate option for our patients with the idea that this was reducing their risk of thromboembolic events. So the bridge trial looked at this in 2015 for atrial fibrillation patients and essentially randomized 1,884 patients to bridging, no bridging, which means discontinuation of then warfarin, as opposed to bridging with low molecular weight heparin in 934 patients. And so they were followed up for 30 days post procedure. You can see the number that actually followed up were about 918 and 895. And their primary outcomes are arterial thromboembolism, stroke, systemic embolism or TIA, and then major bleeding. What you can see they found in the bridge trial was there are no substantive difference in these groups with no bridging versus bridging in arterial events, but a substantially higher rate of major bleeding, as well as a substantially higher rate of minor bleeding, which, of course, a minor bleeding event related to bridging after a surgery will lead to a longer length of stay, more hospital resources, as well as the potential for further iatrogenic complications, including infections. So, however, one of the key points that was important to note with the original bridge trial is that the CHADS2 distribution, which of course is your scaling for thromboembolic risk and AFib, there were actually relatively few patients with CHADS2 scores greater than 4. So the thought was, are we selecting the right patients for a bridging therapy appropriately? The other study that recently came out is a study that essentially looked at the big dalteparin or placebo in patients with both atrial fibrillation and mechanical heart valves. And this is under 1,471 patients in 10 Canadian centers. And what you can see is both with atrial fibrillation and with mechanical heart valves, there was no statistically significant difference in the venous or arterial thromboembolic events in patients who had bridging versus no bridging. And there was actually no real difference in major bleeding rates. The 2.0% bleeding rate was in no bridging and 1.3% was in the bridging group. So realize that the anticoagulation bridging did not make a difference in this cohort of population. So I wanted to come to this, which I think is a landmark guideline that I suggest you all take a look at. This came out in September. This is an update of the 2012 guidelines of the perioperative management of antithrombotic therapy from the ACCP. This document addresses 43 patient PICO questions, and PICO is the acronym that refers to patient intervention, comparator, and outcome related to the perioperative management of patients receiving long-term oral anticoagulants or antiplatelet therapy and require an elective surgery or procedure. So we're looking at vitamin K antagonist or VKA, specifically warfarin, use of perioperative heparin bridging, typically low molecular weight heparin, management of the direct oral anticoagulants, and management of the antiplatelet agents. So I will go through some tables from this because I think this is important. And the visual aspect of this is really important. Patients who have minimal bleeding risk, an example of that is cataract surgery, do not need to stop warfarin. You can continue warfarin through the procedure. And I'll give you an example later of a table that has the surgical bleeding risks, but realize that if there are minimal bleeding risk, continuing warfarin is completely acceptable. Dermatologic procedures and superficial procedures can be continued. If you're going to discontinue warfarin, you'll discontinue it at day 5, and then ideally resume it at 24 hours, within 24 hours of surgery. Again, this is always a conversation with the surgeon about when hemostasis has been achieved. So realize that that is a conversation that's needed. In addition, patients who are high bleeding risk, the same argument takes place. And then the idea of low molecular weight heparin as bridging for selected patients. So there's really no difference from a warfarin standpoint for low versus high risk for bleeding, except that if you're going to bridge with low molecular weight heparin, you may wait until approximately 48 hours versus 24 hours after the elective surgery or procedure. In terms of direct oral anticoagulants, this is a fairly busy slide, but the simple way to put this is if you look at low to moderate bleeding risk for every agent except dabigatran, you would want to discontinue that the 24 hours before elective procedures for low bleeding risk and 48 hours before elective procedures for high bleeding risk. And then the resumption of those can be essentially on day zero for low or moderate bleeding risk, and then you probably want to go to day 2 for post-procedure resumption for high bleeding risk. That's a little different for dabigatran, which is a longer length mechanism of action. So you'll stop that 4 days before procedure or 96 hours for high bleeding risk, and then 48 hours for low bleeding risk. So this gives you a visual depiction of the appropriate discontinuation of DOACs around elective surgeries. These do not require bridging. So recognize that this is a template that can be leveraged. In terms of antiplatelet agents, this is a big controversial area. You'll see at the top that aspirin is recommended, if at all possible, to be continued through the perioperative period, including on the day of surgery. This clearly is a conversation with your surgeons to weigh the bleeding risk. If it should be discontinued, it should be discontinued 7 days preoperatively for things such as neurosurgery. So generally, you'll ask the question, is their bleeding risk high, and is also the consequences of bleeding high? So it's one thing to say if your bleeding risk is high because it's a vascular tumor on the skin, as opposed to it being a neurosurgery where you're bleeding into the intracranial space, has a much higher stakes. So recognize that the recommendation, when at all possible, is to continue aspirin through the perioperative period. The discontinuation frames for the P2Y12 inhibitors, which includes clopidogrel, ticagrelor, and prasugrel, is 3 days for ticagrelor, 5 days for clopidogrel, and 7 days for prasugrel. Cangrelor or bridging with P2Y with the GP2B3A inhibitor is another consideration. They do not recommend that in this guideline, but recognize that resuming P2Y12 inhibitors or Cangrelor in the postoperative period is between 4 and 6 hours. So go ahead and get that started as soon as possible if hemostasis has been achieved. They actually specifically recommend against bridging for most conditions now, with the exception of an older mitral valve, such as a ball and valve type mechanism. If the patient's had a recent arterial thrombotic event in less than 3 months, or they've had a prior perioperative event. In patients with atrial fibrillation or venous thromboembolism at low to moderate risk, they do not recommend bridging. The exception, they say, is if they have a recent or less than 3 months event, if they have a high CHADS2 VASC or CHADS2 score, consider bridging in that patient population. So what is the risk stratification? So here's your risk stratification from the ACCP, the high, moderate, and low risk categories. This is the patients who have mechanical heart valves, atrial fibrillation, or venous thromboembolism. I won't read through these in granular detail, but these are the old model cage ball or tilting disc valve in the mitral aortic position, recent stroke or TIA. If patient's moderate or low risk, it's a bileaflet AVR with or without major risk factors for stroke. In terms of AFib, I gave you the CHADS2 and CHADS2 VASC scores, and then certainly timing of VTE as well as risk factors, including thrombophilia, antiphospholipid. If there's a vena cava filter, that is considered high risk category, and if there is active cancer. Again, the others, dental procedures, it's recommended specifically that you continue vitamin K antagonists, consideration of the use of a prohemostatic agent such as tranexamic acid mouthwash in that procedure, dermatologic, ophthalmologic procedures, and ICD or pacemaker placement are specifically called out as a patient as continuing vitamin K antagonism. There was a New England Journal article that highlighted that bleeding risk was actually higher with bridging compared with continuing the vitamin K antagonist. The exceptions for the ophtho procedures, and we have an ophthalmology satellite, as I talked to you about. If it's a retinal surgery, remember the retina is fairly vascular, but the anterior chamber of the eye is bloodless. So cataract surgeries are typically bloodless procedures. Ophthalmology procedures that have retinal or extensive procedures certainly would consider discontinuing, and that's a conversation with the ophthalmologic surgeon. And again, here's the terms of high risk procedures in terms of conditions. So these are conditions that are considered high risk based on CHEST 2022, based on ISTH guidance statements. I won't read through these in granular detail, but this is for your reference. For low or moderate risk and minimal bleeding risk, we discussed this: derm, ophthalmology, dental, pacemaker, ICD placement. And low to moderate include many endoscopic type procedures as well as cutaneous procedures. So I will stop there. And again, I'm truly appreciative of the opportunity to speak to you. I hope that you will recognize the value add of hospitalists in perioperative care, recognize that communication and collaboration with surgeons and anesthesiologists is crucial to success. Patient with SARS-CoV-2 infection should be delayed 7 weeks for elective surgery. Recognize that you need to have a risk-benefit conversation if surgery is more urgent. Be sure to leverage validated risk scoring systems in patients with cirrhosis requiring non-cardiac surgery. Optimize them as best as possible to ensure that the site of surgical care and that care you're delivering is appropriate. And then certainly utilize the evidence-based guidelines as I highlighted in the 2022 CHEST guidelines updated for anticoagulation and antiplatelet management in the surgical milieu. So with that, again, I'm privileged and thankful, and I'm more than happy to answer any questions.